Thank you very, very much for joining us this evening. This is very much a first for us, as we are doing a joint event between the two companies. Certainly from our side on Wesleyan, it's a first for us. We'll tell you a little bit about the two companies in a moment. But this evening we're going to talk a little bit about primary care networks, and as you can see from the slide on the screen, managing your risk within those. And a joint presentation by both Wesleyan Financial Services and DR Solicitors. So, if I can, I will just introduce you to our to the panel this evening, and you hopefully see the three of us gentlemen across the top of your screens, or have you got the format there? So, to introduce myself first, my name is Graham Layfield. I am an account manager within Wesleyan Financial Services. For those of you who may be less familiar with Wesleyan, we are a specialist financial services provider. We have segments that look after the dental side of things, our education side, and our medical division. And our medical division is split between hospital doctors and general practice. And my background is 17 years now with Wesleyan, exclusively within the general practice side of things. As my colleagues on the panel have already pointed out, I've cheated by using a very old photograph of myself on the panel there, picture there. So that's who I am. Kath, would you like to introduce yourself?
Hi, good evening, everybody. My name is Kabir Ahmed, and I am the GI Commercial Manager here at Wesleyan. My specialism in the background is insurance solutions to medical and dental professionals, in particular managing sort of risks around the practices, and that includes several different sort of business insurances, whether that be liability insurance or products and services insurance. We've been doing insurance here for over 15 years, and as I said, we specialise in the medical and dental sector. Niels, would you like to introduce yourself?
Yes, hello everybody. I'm Niels Christiansen. I'm the Managing Director of DR Solicitors. So if those of you who don't know DR Solicitors, we're a specialist firm of solicitors. We only work with primary care, that's all we do. And we do everything to do with primary care, from partnerships to property to employment to the regulations, contracts. We work at GPDF, the LMCs, etc. And importantly, we've worked really closely on PCNs. So I was involved from the very beginning with PCNs. I worked with Nigel Watson on the partnership review, and the design of them, the thinking of them, we've been involved with from very early on. We now act for about 250 PCNs, and the whole way they work is something that we've been working on from the day one, and the issues that arise with them. And in many ways, what we're going to talk about tonight, to be honest, is the issues many of them are structural, and those structural issues are things that we've been aware of for 2 years, or 2.5 years now it is, and many of those issues are beginning to come home to roost. So it's really great that you're all here, and I hope you find the talk interesting, because the issues can be resolved both from a legal perspective, but you can also look at some of the insurance ways to manage risks as well. So we thought we'd bring all of that together, and hopefully that will be interesting and insightful for you all. So what are we going to talk about? First of all, what risks are there from a PCN perspective? So, try and identify the full set of risks. And I think what you'll find is that when we talk it through, these risks are common to all PCNs. They're not. Don't feel you're alone. You'll find that the risks are common across all PCNs, because many of them are structural. Then we'll look at, well, what do you do about that? How do you mitigate those risks? What options do you have to do so? And you can mitigate them either through structural things, or some things you can't do anything about from a structural perspective. Then you have to look at other options, and those other options might be things like insuring against those remaining risks, or indeed accepting them. That's entirely up to you. Risks are something you once you understand them, you say, well, am I happy bearing those risks, or do I want to deal with them? And what we're collectively going to talk about is your options for dealing with them. And then, of course, we're very keen to answer whatever questions you have. And as Graham said, please do put them in the chat. and Graham will help take us through those questions and either deal with them as we go or at the end. So that's the agenda. Let's have a look at what those key risks are then. So the first thing is, in PCNs, you've got this imbalance. You'll all be familiar by now with the concept of a lead practice model. That's something we've been talking about. People have been talking about from the very beginning. Lead practice model meaning a practice takes the lead in the PCN and employs most of the R's resources. Now, when you only had 1 or 2 resources, that wasn't such a big issue. But now you've got many more resources. If you're following a lead practice model, then of course that practice is taking a lot more risk than anybody else, because obviously when you employ staff, sometimes things go wrong. It's just the nature of employment. And when things go wrong, the employees will look to their employer. And if that employer is a lead practice, then the lead practice is the one who has to deal with it. And indeed, if there are costs to follow, they have to pay those costs. Now, if you've got a well-drafted PCN schedules, then that lead practice can look to the other practices to chip in and contribute to any costs, but that's not a terribly comfortable place to be for the lead practice, because obviously they're taking more risk than the others. So as it gets bigger, it becomes less comfortable to be a lead practice. So what can you do? Well, you could use a flat practice model, which again, this term is fairly well understood now. What it generally means is that you're sharing the risk around. You generally will look to share the resources around the PCN by having different practices employing different resources, and that's kind of works by sharing the risk, because you've at least reduced it on a single practice. The problem with that, it then introduces other problems, such as the fact that the PCN resources will inevitably have different terms and conditions depending on where they're employed. So you could have a clinical pharmacist engaged in practice A on 22 days holiday, and a clinical pharmacist engaged in practice B on 25 days holiday. If they only work in those practices, that's not such an issue. But if they work on a shared basis, which of course is the idea with PCNs, then it is an issue, because you've got resources who superficially appear to be the same when actually you're engaging them on different terms and conditions. And you can't really get around that, because if you try and make the PCN resources have the same terms and conditions, then they'll be different from the other staff within the one practice. So you can generate these practical operational issues if you try and mitigate your risk using a flat practice model. Then there's the famous irrecoverable VAT problem. So VAT, I'm sure if you've had anything to do with PCNs over the last 2.5 years, you're probably sick to death of hearing about VAT. The reason for that is because it's structural. Because any transaction that happens between businesses is potentially a VATable transaction, and indeed HMRC would say it is a VATable transaction unless you can show me why it shouldn't be. And when you share resource or indeed anything else between practices, you are creating a business-to-business transaction. So if an R's resource is if a nurse practitioner is employed in practice A and spends some time in practice B, then there is a business-to-business transaction going on, and HMRC will say, well, I want my VAT, please. In year one, it wasn't such an issue, because you could say, oh, well, we don't do it enough to cross the VAT threshold, so therefore we'll simply ignore it because we're not big enough. Now I'm afraid everybody's big enough. You're all turning over probably about $1 million, $1.5 million through your PCNs. That goes way beyond the VAT registration threshold. So then you have to look at, is it actually a VATable transaction? And the answer to that is nobody knows. It's really, really hard. Just because you are GP practices doesn't mean to say that you're completely outside the scope of VAT. It all depends on the detail of what that transaction is. The one I like to talk about is the Jaffa Cake case, which demonstrates the complexity of VAT. Cakes are exempt for VAT, biscuits aren't. So what's a Jaffa cake? Is it a cake or is it a biscuit? And this went through huge amounts of tribunals and everything about 20, 30 years ago to determine whether or not it was a cake or a biscuit. If you're interested, I'll tell you the answer afterwards. But the difference in terms of whether it's vatable or not hung on that question: is it a biscuit or is it a cake? Now that was just a Jaffa cake. Can you imagine how difficult it is when you're looking at the kind of services that are provided within a PCN? That's why VAT is a difficult issue. It's really complicated, and if you get it wrong, it's really expensive, because you've then got to add 20% to all of the costs. So that just add 20% automatically to the costs in the PCN, because you can't recover it. So it's really, really difficult issue, which is simply baked into the structure. The next problem is a problem of success, really, that these days everybody thinks that PCNs are the solution to all of the problems in the NHS, which obviously is pushing it a bit, but it nonetheless, it means that PCNs are receiving lots of opportunities to get additional income. And indeed, you know, even the letter that came out a couple of days ago about the ICSs and the way they're going to work. Have you noticed how everything talks about PCNs now and much less talk about practices? Well, what that means is there's more income coming in at PCN level. That seems to be on doubt. What it will be, I don't know, but there's certainly going to be more income. And also, as you've got more resources, you're going to have to put them somewhere. Now, eventually you run out of space in your practices, so where do they go? You're going to have to find some additional space, and you're going to have to start contracting for leases and stuff. Do you want to put those into your practices? So because the PCN doesn't have a contracting entity, that becomes a problem, because the PCN is just a contract. Until you have an entity you can call the PCN, the only thing you've got left is the practices, and the practices then have to, in the same way as they're engaging the staff, they'd have to take leases, they'd have to take contracts, all of which starts to become a little uncomfortable. Then, in the current model, you start having potentially governance issues. Now, in a practice, things are generally well governed, because in the end, you know, it's your money, you know the parameters of what the practices are, you know who your employees are, you know what your income is, you know what your costs are, and then it's kind of well governed. The partners will sit around the table with the practice manager saying, let's talk through all of this, let's understand where we are, we know what's in the bank, all of those basic governance issues. In my experience, and unsurprisingly, that is not the case with many PCNs, because in the end, who owns the PCN? Whose job is it to understand what's in that bank account today? In reality, there's usually only one practice that can even see what's in the bank account today. Who's reconciling? Who's making sure that you claim back all the income you should get? Who's making sure that all the expenses are properly paid? All those sort of basic fundamental governance issues are often not there. Often I just see some calculations on a spreadsheet. And that's worrying when you've got over £1 million going through a PCN, because eventually something goes wrong. So those problems are then built upon unlimited liability, because obviously most practices are unlimited liability partnerships. And so if you don't have an entity called the PCN, where does the buck ultimately stop with this stuff? Well, ultimately it stops in the only entities that exist, which are the unlimited liability partnerships. So all of those problems above, if any of them go wrong, they end up in the unlimited liability partnerships. And what does that mean? Unlimited liability means ultimately the partners in the practices are at risk, all the way down to the shirts on their back, basically. So it starts to become uncomfortable, because there's no structure there. And then the next one really is this risk of an accidental partnership, because there is only one entity, one legal entity, that you can create which you don't do deliberately. Because if you want to set up a company, you'd have to go off and set up a company and go through various processes. The same with limited liability partnerships. Indeed, any entity other than a single person, you have to do something actively to set it up, except for a partnership. A partnership is the only business vehicle that you can set up just by accident. And that's because a partnership is simply a legally defined term of art. A partnership is basically defined in law as one or more, no, two or more persons in business together for profit. When PCN started, it was all about cost sharing. It was all about just sharing costs and share ours resources. There was no profit involved. You were supposed to just be sharing costs. What's happened over the last year, particularly with COVID, is that many PCNs have actually made surpluses. How have they done that? Well, that's because you're paid per jab and your costs are whatever the costs are. So when you have that kind of scenario of shared income, less shared costs, rather than just cost reimbursement, that starts to look an awful lot like profit, in which case you have to ask yourself, have PCNs accidentally become partnerships at will? And I suspect the answer for many PCNs is actually, yes, they have. So that's quite an uncomfortable place to be when it's completely undocumented. Then you move on to the more operational type risks, and maybe I'll pass to Cam just to take you through these ones. Cam.
Graham, I think long-term absence is yours.
Yeah, long-term absence, very much our sort of area. It's been fascinating to listen to Nils about all those issues, because we're starting to see, as you say, sort of 2.5 years into the life of PCNs, people starting to come back end of the pandemic, fingers crossed, that these sort of practical issues are coming out. And the one thing that we're seeing when we're having conversations is very much that actually you need to understand what the problem is, whereas our world is very much more about trying to get to the solution. And it's really interesting, and looking forward to hearing a bit more about how you address those bits. But what the sort of questions that we tend to then start getting into conversation with PCNs is, well, we have people that need to deliver services, be they clinical directors, be they the bespoke PCN manager or the practice management team from within the network, and you've got people delivering services that actually are essential for that PCN to maintain its operation. And in the same way as we've got at a practice level, we're starting to see the same challenge about, well, what happens if these people are not here? I'll use a clinical director as an example, and tying in with what you've been saying, Niels, about the how you structure things. A clinical director funding could go directly to a practice, and the practice are using that to cover the cost of that person not working their sessions. But if that person's not available, does that funding continue? Whose responsibility is it? The practice, or is it the PCN to replace that person? And we've seen both. We've seen PCN managers recruited and paid for through core funding, and if those people go off, who does that work thereafter? And then you've got the question of of all of those staff employed under the ARS scheme. And ARS, whilst there's no absolute entitlement to cover sickness, the expectation, and you referring to the NHS's own guidance now on this year's contract, says the expectation is that you would still be able to receive funding for the any sick pay within the contract of the absent person. You would potentially be able to go back and recruit and receive funding for an additional person, but that very much depends upon where you are within your hours, because it is absolutely subject to there being available funding within your hours sum. So if you are a PCN who are pushing towards the top end of your funding, or you've got plans to do so, how do you protect those plans if people start going off and you incurring other costs? It's one of the questions we have. We also are starting to think questions about data protection, which is very much Cab, something that you wanted to talk about.
Yeah, so I mean, even before PCN networks were in place, data and cybersecurity is always up there, sort of high in priorities when it comes to insurance. With obviously GDPR coming in, then there's new rules and regulations, fines, etc., etc. What the PCN has brought in, this extra layer of risk involved. This is where data or patient data or employee data is moving further away from the practice itself. So where before, I suppose, it was isolated within the practice, and then you had the whole NHS infrastructure there for the cyber protection. Now this data is then moving into the PCN network and then shared between other practices, other members of that PCN network. And that could be, I suppose, not just sort of other GP practices, but you could have your pharmacies, you then have care homes, other sort of voluntary care providers, if you like. So data is moving from one place out to lots of different places. And it all boils down to who is ultimately the data controller and data processor, who is responsible for managing that. So that's something that needs to be identified, and I'm sure most of you would have done that. But the risks there, I suppose, if you look at it from the finance point of view, PCN is responsible for all the funding. They then distribute it out to the members, sort of PCN network members. What if an email is intercepted between payments and account numbers get intercepted? Where is that sort of money going? Well, hackers can quite easily intercept an email, change the account numbers, and all of a sudden money's disappeared. Who is then responsible? You then have other cyber risks in terms of hacking, shutting down systems, ransom. So there's lots and lots of layers involved within that. The other side of it is then becomes the actual running of the PCN network. So obviously we've heard the big term clinical directors. Well, what is exactly a clinical director and what capacity are they involved in? What are their sort of responsibilities? Now, I'm sure you all have probably looked at the PCN handbook from the BMA, and they provide some sort of key considerations when it comes to sort of setting up or managing the whole network. And one of the big factors is the actual decision making here. Who is responsible for making the day-to-day decisions of how the operation works, how the network is responding, and ultimately, where does the buck stop if something goes wrong? If there's an issue with, I don't know, for example, employees. Well, if they're moving from one surgery to another, well, what happens if there is an injury or something to them in another practice? Who is responsible for that kind of liabilities? You then have the HR processes, the policies, and all that in place that could be set by these clinical directors. But ultimately, the responsibility lies within them, and it's not the actual practice or the PCN that's going to be held liable. It is them themselves who will be held responsible. So we'll come more into those two areas in terms of how you can mitigate it and talk more about the protections that are available later on in the section. Nils, back to you.
Yeah, thank you, guys. So,
just on the personal liabilities, just one final thing. Sorry to interrupt the notes. Just saying about the personal liabilities. The other thing that really wants us to flag is that within the networks, the clinical directors, within the PCN leads, within that, depending on what you've changed, your circumstances have changed. If you are receiving an income in a different way, if you are we've had people give up partnerships to become full-time clinical directors, and sick pay arrangements have been almost an afterthought. So little things like that. So don't forget the absolute personal liabilities and issues for PCN leaders. Sorry, Nils, I jumped in.
That's
there.
Okay. And well done for Cab for reawakening your lights. Thought you'd had one of these. Okay, so what can you do about some of those things? Now, basically, the thing about risks is that you have to analyze them individually and say, what can you do? Many of these we've talked about are structural, and some of them are operational ones. The more structural ones, there's actually, if you've got a structural problem, best way to solve a structural problem is to change structure. And there are three different structural options that you can use to address the structural type issues. Now, the first one of those is you can, if you like, merge all of the practices in the PCN into one. So by creating a single practice, that practice effectively becomes the PCN. Well, not effectively, it is the PCN. And there are a number of these around in the country. There are, if you're lucky enough to be a practice which is big enough to be a PCN, or if you merge the practices within the PCN into one, it solves the problems, because there's no sharing that goes on. All of the activity is within the one practice. However, it's one of those things which theoretically sounds fine, but would you really do that? Would you really do that just for the PCN? you know, ultimately practices are not merged for perfectly good business reasons, because usually you don't want to, and because you run them differently, and because you like running your own business and you like to be an independent practitioner, and they run it differently down the road, and why would you want to run it like they do? So it's like your accountant saying, you know, get married, there's loads of tax advantages. Yeah, but you don't really do it for that. And that same thing about merging practices. So of the 250 odd PCNs we've worked with, 2 of them have done this, and they were both 2 practice PCNs who had anyway been talking about merging. So yes, in theory, but really not the choice that most PCNs are going to do. So that leaves you 2 choices. Option 2 is to collaborate with the federation. Now that works. But if you move, if as a PCN, you move all of the PCN activity into the federation, and the federation employs all the R's resources and sets up something called a VAT cost sharing group, and contracts from the federation, you can do that and you can minimize many of these structural risks. The problem that we often see here is this something you really want to do? Because what you're doing is you're passing all of the PCN activity to the federation. Now, if all of the practices in the PCN work really well with the federation, then that's great. If that isn't the case, then it becomes more challenging. So this really comes down to a governance choice of how well, first of all, do you have a local federation which you're happy to work with to do this? And secondly, what are the relationships like between the practices and the federation? Because ultimately federations are not PCNs, they are much bigger than that. So therefore they're governed in a different way. They're governed generally at a level of about CCG. So you, as a result, if you're a PCN, you have to ask permission from the federation before you do things. And if you've got great relationships, that's super, and it works in many places across the country. If the relationships aren't so close and you want to have more control of your own destiny, then it may not be the answer for you. So for those who don't want to do that, what is the answer? The answer is actually that what we call incorporate the PCN. I think, to be honest, I was the person who thought about the word incorporate PCN, and I'm actually regretting it a little bit, but everybody uses it now. So well, that's what we tend to call it. But what you're really doing is you're setting up a company for the PCN, for the core network practices to own, and then you move all of the PCN activity into that company. It's a captive company. I actually prefer to call it a shared service center. It's a company which only does what the PCN wants it to do. So it only does what the practices and the PCN wants it to do, nothing else. And it's controlled by those practices, and its only function is to do shared things for those practices, of which the most obvious shared thing is the PCN DES and all of the activity within the PCN DES. So that is the option which I'm going to look at now, because it's the one which requires you know, the most thinking about, well, how does it work? So if you want to set up a shared service center or incorporate your PCN, as it's called, you've got to think about the structure and the way it works. So what is it? You've got to start with, what is a PCN? Well, the PCN is the core network practices, however many you've got, be that 2 or 10 or 15. What they define is the geography of the PCN, because that's the sum of the practice areas, and they define the population, the 30 to 50,000. So those are the core network practices which form the core of the PCN. Now, there's a reason it's called the core network practices, is because that isn't actually the PCN. Common mistake is to think that they are, but they're not. The PCN is bigger than that. The PCN is the core network practices plus any other members who you want to admit. And so you could admit people like community health, mental health, community pharmacies, whoever you can think of who delivers health and care to the defined population in the defined geography. You can admit, you don't have to, but you may well choose to do so, because if essentially, remember the real purpose of the PCN, and this sometimes gets forgotten about, I think, in all of the sort of people talk about the problems and everything else, but what's the real purpose of the PCN? It's actually to improve health and care services for the 30 to 50,000 patients. And you can do that by working more closely together as practices. But if you want to make a real difference, you've got to work with the other organizations, the other entities who provide health and care. The real PCN is actually this big block here. It's the core network practices plus the other members. So that's your PCN, and you have your PCN schedules, PCN agreements, which set out the rules of how you work. That doesn't change. That doesn't change at all. What you do is you actually add to that. And what you add is a PCN company or a shared service center, call it that, but it's in the form of a company. And that company is owned by the core network practices. It has nothing to do with the other members of the PCN. It's just owned by the core network practices. They logically would be shareholders in the company, and in that way they become members or own the company. So you set up a company owned by the core network practices, and then you move all of the PCN activity, but only the PCN activity, so all the R's resources typically, but potentially other things as well, into that company. In many ways, what it does is it rolls back the activity from within in the practices to where they were before PCNs arrived, because you've still got all your ordinary staff there and all your ordinary GMS activity, but the PCN activity, so the R's resources, move into the PCN company, and the PCN company supplies those staff and other services back to the core network practices. So what you do is, instead of having transactions between practices, you then have transactions from the shared service center to the practices. Now you think, well, that's a bit of a funny thing. Why would you bother doing that? Well, it's a number of reasons why, and one of them is what we call a VAT cost sharing group. So if you set up your shared service center this way, you can create something called a VAT cost sharing group, which is that red line around the core network practices and the PCN company. So long as the PCN company is providing the services to the core network practices, all of the activity within that that sort of big red circle is outside the scope of VAT. So instead of worrying about whether a Jaffa cake is a cake or a biscuit, you really couldn't care. You still just eat it. It just takes the whole lot outside the scope of VAT and resolves the VAT problem, so long as you follow a series of simple rules. And those rules are that the company must be owned by the core network practices, which it will be. It needs to be directed by the PCN representatives. So the PCN, getting the governance right around this is key. So what you need to do is think through, how do I avoid this company developing a mind of its own and going off and doing other interesting things that companies can do? And that you do by making sure that the governance of the company, in particular the directors and the shareholders, are actually the same people as the PCN representatives. If you make it that simple, PCN representatives equals shareholders equals directors, then the company is just doing what the PCN representatives want it to do, and the PCN representatives do what the practices want it to do. So by keeping it that simple and tying the governance between the PCN and the company, it just becomes a shared service center. You then move all of the R's resources into the company. By the way, the company will be eligible for the NHS pension, because you can, what you do is you apply for something called NHS pension dispensation. And when this first started, it wasn't possible to get this, but this is now possible. You apply for dispensation, and all the resources which are in that company can get the NHS pension, which is super. So that solves that problem. You then move all of your other contracts into that company as well, if that was, subcontracts or leases or whatever it is. So basically you move all of your costs, your PCN costs, into that company, and then the company supplies those services, be that R's resources, be that space in a lease, be that a subcontracted mental health worker, whatever it is, they get supplied at cost, and it's really important to remember, at cost back to the practices. So from a flow of money perspective, PCN money comes in the DES at the top into core network practices, and into a nominated bank account, and then from there, the nominated bank account pays the company for whatever services is provided at cost. As long as you do that, then you are within the scope of the VAT cost sharing group, and all of your problems there are solved. Neatly, this isn't some HMRC solution to PCNs. What it actually is an HMRC solution to the fact that some businesses like yours can't recover VAT, which is unfair because businesses like ours can, but you can't, and so therefore it's not fair because you can't set up shared service centres. We can do it because if we set up a shared service centre with somebody else, like with Wesleyan, well, Wesleyan and DR Solicitors are both VAT registered. We can both recover the VAT. So to be honest, we don't care if we generate VAT. You do because you can't recover it. So this is an exemption which is designed to enable sharing between organisations like GP practices. So think about that. That means that anything else you fancy sharing as well, you can also put in your shared service centre. So if you fancy doing a shared back office or buying products together or buying insurance together or whatever you fancy doing, you can do it through the shared service centre, and that can get you economies of scale. So that's a really useful little additional benefit of doing this. And then what you do is, if you do manage to generate profit in that, which of course you shouldn't do on year one because of that cost sharing group, but future-proofing it, you've now got an entity which could contract. And if it contracted and decided to, let's say you get a contract at PCN level, which remember is going to happen because all of the money is flowing to PCNs, you get a contract at PCN level, you may decide to start delivering services through your company, which nobody's nothing to stop you doing that. You then generate profits in there, and then you need to think about how you get that money out. So you do that through dividends, through something which we call alphabet shares, which enables you to have different dividends for each practice, and then you can just share the profits out based upon list, so long as it's set up properly, or indeed upon any other basis you've got. So by structuring it, you can A, benefit from the VAT cost sharing, and B, you can get you can solve many of your other risks. So this is the structure. This is the structuring option of setting up a shared service centre. Incidentally, this is also the way that if you go down a federation model, that's actually also what's going on in the federation model. The only difference is that the governance is different, because instead of having the PCN representatives the same as the directors, so you have one meeting and make the same decisions, those are different. So the PCN representatives make a decision, then go to the federation and say, can we do this? But other than that, the basic structure is the same, which is why through a federation you can get the same benefits. So that's the structural solutions, and then, but not all problems lend themselves to structural solutions. So if we look more at the operational things, I'll hand back to you guys to talk through things like options to insure for long-term absence.
Thanks, Niels. I've seen you do that a couple of times, or those slides, and I learn something every time I see it. It's fascinating. But I think that's a really, really important point. And we knew when we were putting this sort of joint presentation together that a lot of the conversation was going to be around the structural stuff, because that's so important. That idea that if you can mitigate as much of your many of your problems and many of those risks that you listed by getting your structure right for you, what that then leaves is these operational problems, and you're back into the sort of challenges that we have at practice level. Let's take that example of the incorporated PCN. Suddenly everybody's employed by that group. We have a group who have clear liabilities, and you then know these are our remaining risks. And Niels, you mentioned earlier, with those remaining risks, you've got a choice to either accept them or do something about protecting against them. And long-term absence is probably the most common thing. Now, we've had an extraordinary 2 years right across the world, and one of the things that we're getting lots of questions about now at all levels of primary care is about, well, what can we do? We're expecting rates of absence and the consequences of all the last 2.5 years to come home to roost, is what we're being told. But the great news is, if you've gone through the process that Nils has said, and you've decided whatever your structure is, we're then in a position to say, right, let's look at these remaining risks. Let's look at long-term absence. Let's look at what would happen if your clinical director or your practice manager leads, or your PCN manager or your R's staff were off absent. Take the R's staff there. The first thing we look at is the capacity you've got within the funding to pick up those. Are you at risk of incurring additional costs? Do you have a lot of capacity? If it's the latter, you're probably okay to leave it as it is. But actually, if you're at capacity on the funding or getting close towards it, additional costs become then a network cost, and then what funding you have, it will probably be passed on to the network. So can you protect against it? Great news is exactly the same as we've been doing for years at practice level. You can protect against those absences of the people employed through the PCN, be they through the R scheme, or be they clinical directors, be they managers, or whatever. There is a solution available to you. Clinical directors is one I just wanted to pop on. I mentioned earlier about the different ways of funding, because in some situations, and many situations, the funding for a clinical director goes to the practice. So again, an example of making sure you understand your structure is who's liable to replace that person if the clinical director is absent for 6, 9, 12 months. Is it the PCN or is it actually the practice? And we've actually had both scenarios. But again, finding the solution to protect it isn't difficult. It's making sure that the right person takes out the solution, and that comes back to getting the structure and understanding where your liabilities lie. So that's really a very, very simple message, that once you understand your structure and you know what risks remain, talk to us. We can look at what your options are to do so. And it falls down to that very, very simple decision of, is this liability one that we're prepared to accept within our network, or is this one that we actually need to do something about, moving that liability away from us and onto an insurance company via a policy? So that's very much the long-term risk. Cab, you talked about some of the problems with potential risks around cyber and data. What sort of solutions it would be about?
Yeah, so with data and cyber, I think the first and biggest and probably the most cost-effective sort of solution to data and cyber, it starts with the staff, you, and everybody else who handles that data. And I suppose predominantly the important thing is making sure you have rigid training plans in place to help staff understand what data is, what they're doing, and how they're handling that data, and what they can do to prevent it. So obviously most systems, I think, ever more so now in the digital age, and particularly when we are logging into systems, there's these two-factor authentication or multi-factor authentication when you're logging onto systems. So get those added onto the systems. But then it comes raising awareness with staff, so making sure they understand what phishing and all these sort of digital hacking terminologies are, making sure they understand. So simple things like, opening up an email with something that they might not recognize or doesn't look right. Classic example, I'm using me as a person. Now, I work in insurance and I should understand these risks, but I felt sort of victim to it. A few months ago, my TV license, I knew in the back of my head it was due at some point. I had an email come through to say your TV license is due. Can you log in and put your account details in there? And because it was in the back of my mind it was due, I replied to the email, put my account details, and within literally half an hour, all I'm getting is notifications to say, there you go, and you've spent money in Apple or somewhere else and somewhere else. And it can be easily done because it looked exactly like how you'd expect it. And these things are often easy to do and easy to fall prey to. But when it comes to PCN network, as I said, this data is now being shared across platforms, across businesses. Inevitably, how do you protect that? Well, the only way you can protect that is either to accept the risks involved or get yourself some sort of cyber coverage. And what that cyber coverage will allow you to do is not only help against help against the cost that you could be incurred. Now, whether that's the fines and things that come from the information commissioners, ransom that's demanded against it, but more importantly, the reputational damage that it can cause if something leaks out. So investing in a good cyber and data security insurance would be one example. But more importantly, and I would say the one thing which is cost effective, make sure you raise awareness with your staff constantly. There's always something, some email somewhere waiting for someone to click on and almost hack into their system.
Nils, I think
other part which we talked about. Sorry.
So Nils, I'll just.
Nils, sorry.
Just to say, I think in previous conversations you've mentioned the importance of data sharing agreements as well.
Indeed, I mean, as part of your PCN, actually, you've signed up to that you will sign a data sharing agreement between the practices, and of course, if you involve a company, you need that as well. In my experience, keep it to yourselves, but I don't know many PCNs that have done it. Now, why is that? That's because, to be honest, it's quite hard, because you can't just sign a data sharing agreement. And I know there are templates out there. There's 2 templates which were issued, and they were issued because there's a lot of pressure on people to issue the templates. But the reality is, to get data sharing agreements right, you've got to get down into the nitty gritty of what's really happening with the data, which means within the PCN, what you actually need to do is go and understand what is everybody doing in terms of data sharing. So your clinical pharmacist, what are they actually doing? They're employed in practice A, they're doing something in practice B, but what are they doing? And until you've understood those processes, you can't really, to be honest, even document a data sharing agreement, because it's those processes which define who's the controller, who's the processor, what's the data, and what should go on the on the statements. So unfortunately, data sharing is a really, really horrible area where, in my experience, most PCNs actually need to do a lot of work before they can document it, and then they should come to us and get the data sharing agreement. Far too often people come to us and say, can you just write a data sharing agreement? As well, yeah, but what are you sharing? That's unfortunately the work that needs to be done. So sorry everybody, but that's a bit of homework for you to get that one right.
Yeah, and that kind of leads nicely into presents another risk there in itself. So Nils, as you mentioned, obviously there needs to be processes and guidelines in place. Now, what happens if the lead clinician or the manager, whoever's managing that PCN and is responsible for that, what happens if they do get that process wrong or misadvised or misinformed? Well, what happens then? Who's going to be held responsible here? That then becomes sort of the personal liability onto the leader. Now, as a PCN, forget using the PCN sort of clinician, as a owner of a business, and I'm going to use business now because that's what this model is. As a business owner, they have a responsibility to manage the day-to-day affairs in a fair and in a dutiful way. If something goes wrong, ultimately, it's not the business that's going to be held responsible or liable. It's going to be that individual person. Now, that could be as simple as not ticking something on a health and safety sort of process correctly. It could be not having a proper HR process in place. It could be a number of things. Now, all of a sudden, you've got a PCN network, and this business owner who's now been tasked to lead the whole PCN network, they've got this whole other rack of responsibilities across multiple practices and things. Well, who's going to be liable? Well, it is going to be, unfortunately, that individual person, because if something goes wrong in practice B, they will hold you responsible if something's not done. So, for example, if an employee, if a HR process is not put in place whereby how to raise, I suppose, grievances if that process has not been followed or not done. It falls on this person over here, the lead practitioner or the lead clinician. You then have liabilities from, I suppose, running of the business, so the financial sort of situation. So as a lead clinical director, the funds that come in, you are moving that money across equally or dividing it however it is divided across the PCN networks. What if you get accused of unfairness? Well, again, you're going to be held responsible. So there lies another that whole host of risks involved here. It's not just the business at risk, whether it be cyber insurance or the business insurance. You now have personal risks, and unfortunately, that's something that needs to be raised awareness of. And there are insurance policies in place. Going back to what you said, Nils, earlier on, I think the best way to look at sort of risks and how to mitigate it is basically identify the risk. Sit down, work out what the business risks are, what the risks are to individuals, whether it be employees, you as the lead clinical director, what are those risks? Then we'll find out how you can mitigate it, work that out. Now, whether that's speaking to specialists, whether it's speaking to legal counsel, whoever that might be, understand what and how to mitigate it. And I suppose the final bit is then you either accept those things, as Neil said, or you find a way to protect it. Now, there are insurances in place, but unfortunately, the world we live in, not everything is insurable. So some you're going to have to accept, but some you can protect. They can be costly. My advice would be is speak to your insurance broker, speak to a risk specialist, and understand those first and foremost.
Indeed. So if we look back at, the summary of the risks we went through at the beginning, the short answer is that all of these risks, most PCNs are going to have at least some of them, and if not all of them, and they can all be dealt with in different ways, or you can accept them. But the first, or how many it is there, they're structural. They can be dealt with in structural ways, and the last three, they're operational, and you can deal with them in operational ways. Obviously, you want to mitigate your risks by as best you can internally, training, etc. And if you're still uncomfortable, then you look for the insurance, the operational risk. So in many ways, PCNs, in that sense, are no different to practices. But if you get your structure right, then it actually helps and becomes much clearer which entities the residual operational risks are in, and then it becomes much easier to insure them. I'm conscious of the time. Have we got some questions which people would like to ask?
We do. We've got a couple of good ones as well. So I'll find that. Can I just give everybody watching a little bit of a heads up on the final slide that we'll put up after this one? There are a couple of QR codes there. So there they are in front of us. We'll actually, whilst we do the questions, let's leave the QR codes up. And the one on the left there is to contact Wesleyan, the one on the right to contact DR Solicitors, and that will put you through to an inquiry form that you can contact one or other or both if you so wish. Again, for Wesleyan, you can also visit wesleyan.co.uk and Nils has put his contact details there. So if we leave that slide up. So I've got a couple of questions. One from Susanna, which says, isn't this all an attempt by the government to destroy general practice and the partnership model? Nils, I'll leave you that. I'll pass that one to you.
Well, I'll tell you what, this all started, I'm going to name him because I think I should. It all started with Nigel Watson's partnership review. And that's Dr. Nigel Watson on the GPC and chair of Wessex LMC. And what he was asked to do was to write a partnership review which protected the independent status partnership. That was the whole objective of that thing. Now, whether or not he's achieved it, I think, you'll have to be the judge, but that was the underlying purpose of it. And if you think about what's the alternative, I mean, it's very clear that there is a push towards at-scale working. And if you're going to work at scale, you've got to do something. So you could merge the practices. Well, you don't want to do that probably. Or you could get acquired and moved into the trusts. Well, that's happening in parts of the country, and that certainly was on the long-term plan, was that as an option, and it's still there as an option. or you do something else. And this was Nigel Watson's view as the something else. And it was adopted really quickly, and the government adopted it, and all of the papers I see talk about PCNs. Now, you know, I've got no more crystal ball than anybody else, but I don't see how this leads to the end of the independent status, status. I just don't see it. But you know, that would certainly. I can't tell you what the government's going to do. Sajid Javid said he's going to nationalise everybody. Well, maybe he is, but I don't see it myself. But then again, you know, I appreciate some people look at it that way.
I think the honest opinion is we're not able to actually answer that. We can only give you a personal opinion, and certainly the Wesleyan, one of the groups that we interact quite closely with, our advisory board, and that's senior people involved with the politics and senior doctors and so on. And the indication, certainly on the general practice, is that the intention is to retain the partnership model long term, but things will evolve and things will change across the board, and it's very much that high level, but that's about the level of response. Really good question, this one and it's what happens at the end of the 5-year plan, especially if we get a change of government in 2024, and says we've been here before with model changes, i.e. the GP fund holding when that went. So again, we've got a plan from launch in 2019 and commitment through to 2024. Again, I'll give you the Wesleyan understanding, and certainly the guidance from our advisory board is that this shared service model, whether the name primary care network remains, but the idea of a shared service model is here long term, is the indication that we've been told, and it's about as much we can take. But Niels?
I'll give you my crystal ball, and that is that I haven't got a clue. But what I will tell you is that if it was me, I'd be looking to minimise my risks around what might happen after the 5 years is up. Because if you think about it, if after the 5 years the plug gets pulled on PCNs, which might happen, I don't think it will, but it might do, then what? If all of the liability sits in your partnership, then you're going to have to pay the bill to sort the problem out, which is potentially make everybody redundant. I don't know what you're going to do, to be honest. If, on the other hand, you've moved all of the PCN activity into a limited liability company where you have no real exposure to it because you've only got £1 share and you haven't moved a whole load of assets into it, which is the model of the shared service centre, then if something terrible happened, like, for example, the plug got pulled on PCNs, your total exposure as a practice is £1. Whereas if it's in your practice, which is the current contractual model, then your exposure is as big as the exposure is. And don't forget, some of these Rs resources might have 20 years worth of pension on there. And if they have that, that's a very, very big redundancy bill. So if you move it all into a company, you remove almost all of that risk, which is one reason why I think it's quite a good idea to do it. Because I don't have a crystal ball which will tell you what the government will do. I have no idea.
We have one final. Can I just add, in terms of risks, that's not. No, I was just going to say, in terms of risks, that's not going to go away. Whether you are a part of a PCN network federation, however it's set up, the liabilities, the cyber, and all the other risks that are involved, they're still there. And it's always prudent to make sure you do that risk analysis at least every year, just to make sure you're covered and protected in the ways you need to be.
We've got another one there.
I've got two more if we've got a couple of moments. Question: can CCGs pay the NHS fundings now directly into a PCN bank account? Honestly, I'm sorry, I don't know.
Good
that.
question. Good question. So depends where you live. Some CCGs say they can, and some CCGs say they can't. So given that a year ago they all said they can't, it seems to me that there is a move towards that they can. And if you live in the right part of the country, then maybe you've got there already. There's, different parts. So they will be able to. And again, if you incorporate that, then helps because it takes it out of the practices and puts it into a more obvious place. Next one.
Next question. Is it worth a practice pulling out of a PCN given the personal risks and liabilities involved? again, my immediate response is there's no structure that doesn't have personal risks and personal liabilities. And I think my view would be it's about getting those addressed, and much along the lines we've talked about today. But Neil's just certainly immediately going to respond to that one. Okay.
No is the short answer, because you can't. I hate to say it, but PCNs are a bit like Hotel California. You can check out, but you just can't leave, because the reality is that it's in your contracts now, in your GMS and PMS contracts, that you must provide your patients with PCN services. So if you actually try and check out of the PCN DES, you still get caught by it. You just don't get paid anything for the pleasure of doing it. Whereas at least if you're in it, then you have the funding comes in. If you check out, you've got to do this whole lot, but without getting paid. And yes, in theory, the responsibility passes to somebody else, but actually most of the risk doesn't. So my advice is that that's not a path that you want to do without thinking about it very hard, because it doesn't get you free of all of these problems. It in fact creates even more. And I promise you, I'm talking from experience. I know plenty of ones where they tried to do this. It's hard. It's very painful. Yeah, I know it says on the tin you can opt out, but it isn't that straightforward, I promise you. But if you're thinking of doing, please do give me a call and I'll give you a bit more color around it.
Good advice. Yeah, speak to the mouth this man he knows. What are the difficulties with setting up a PCN? Sorry, what are the difficulties with setting up a PCN company down the line? What happens if no one wants to take over from retiring directors?
Okay, so what you do is if you mitigate the structural risk through a company, the way we recommend you do it is that the PCN representatives from each practice simply get 3 hats: PCN representative, shareholder, and director. So that just comes with the job. So unless your practice can't find a PCN representative, but that will then be a problem from a PCN level, then it just follows with that. It's not a question of you be the PCN representative, you be the shareholder, you be the director. Combine the whole lot into one, and it kind of moves with that job. So by signing up to the PCN DES, of course, you're committing to a whole load of governance and committing to being participating in it. So we tie all of those all those together. And if as a practice you decide your PCN representative is going to change, then you would change the other bits as well, the shareholder and the director. So the question then becomes, what if your practice can't find a PCN representative, which would be a problem? So I hope that answers that question.
We've overrun by a couple of minutes, so I'm going to make this the last question. I think it actually is the last question in here, but again, can I just say thank you to all those of you who've stayed with us, and pretty much everybody that we've got the same numbers at the end of this call as we had at the beginning. So thank you for your patience. I hope it's been useful for you. So one more question, and again, Nils, is coming your way. Can the PCN finance practice transfer money to the PCN limited company's bank account, which in turn pays our salaries, etc.?
Right. This is slightly complicated, so just be ready. Okay, I'm going to talk about the money flows and the way it works. The company, don't forget, is within a VAT cost sharing group, because you're trying to avoid the whole VAT problem. And remember, one of the rules about the VAT cost sharing group is that it's at cost. You must pay the company for the services it provides at cost. Otherwise, you move outside the rules of the VAT cost sharing group, and then you're back into the problem that you've got at the moment. You can generate VAT. So what happens is the money turns up, the DES money turns up into the nominated bank account, which for most PCNs is one of the practices, unless you happen to be fortunate enough to live in that part of the country where they allow you to pay into something else. But let's say it turns up in the nominated bank account. Now, that at the moment is all mixed up. It's some kind of big spaghetti mixing practice and PCN money. You separate those two out, and then you kind of put the PCN money into a separate place. Now, if you incorporate that separate place would be in the company bank account, but not in the operating bank account. What we recommend is you have two bank accounts in the company, one being a business current account from which you pay the salaries, and whoever asked the question, it sounded like it would be your salary as well. So you pay the salaries of the employees of the company from the business current account. The second account, and this is the really important one, is a trust account. What that is an account held in the company's name, but it holds it on behalf of the practices. So the PCN money, the DES money that arrived in the nominated bank account, is moved into the company trust account, which is the PCN account belonging to the practices. And then as you need to pay the salaries from the company, you then move money from the trust account into the business current account, enabling the company to be financed. So basically, the short answer to your question is the employees are in the company pays them, but the money to get to the company is transferred from the practices, from the PCN as it's needed, but otherwise stays outside of the company until it's needed. The reason for that is because if you transfer too much into the company, you'll make profits in the company, you break the rules of the VAT cost sharing group. So sorry, it was a bit complicated, but very happy to take that more slowly outside of the meeting before you all sort of want to disappear. Please do give me a call if you want to talk that one through again.
There is a very quick one come through there. If we have got time to translate, what is your exposure as a director of a PCN company?
I've got a good answer to that one. So at the moment, as a partner in a GP practice, what is your exposure? Your exposure is unlimited. You can lose your house. As a director of a company, you do have a residual amount of liability. That residual liability is very small. It's certainly a lot smaller than losing your house. It's perhaps in percentage terms 1 or 2% of the unlimited liability you've got as a partner. There is some there, and I won't underplay it, but you've got to be doing some pretty bad things before that kicks in. You know, it's verging on criminal before that kicks in. That said, if you want to deal with that residual liability, there's always insurance, and these gentlemen would be very happy to talk to you about it. But believe me, it's a lot less than the unlimited liability you've got as a partner.
And I repeat my thanks to everybody who's joined us this evening. And we had one final question, which I'm going to answer. It says, any top tips on how to sleep soundly tonight? I'm very much hoping that the message that we're trying to give across this, and it can be complicated, particularly around the legal side of things, the structural side of things. But I hope those two QR codes there say, look, there are solutions to pretty much everything. The answer to what is right for your network, for you as individuals, will depend on your personal circumstances and what you're trying to achieve. But please do talk to Nils and contact DR Solicitors if you've got questions about the structural side of it, and the more operational stuff, please talk to us. We'll be more than happy to help. And I think if you know that there's a potential solution out there, I hope that will mean that you can sleep soundly tonight. So
I assure you, you can sleep soundly tonight. The problems aren't that big, but the problems are getting bigger. So it's worth thinking about them. They're much bigger now than they were 2 years ago, and they're only going to get bigger. I can only reiterate what Graham said, which is take advice, but take advice from people who know what they're talking about. Look for the specialists, lawyers, accountants, solicitors, insurers. Go to the specialists, because this is quite complicated. It's much more complicated than the olden days. So long as you get specialist help, people who know what they're talking about, you'll be fine. You can sleep at night.